Welcome everyone to our deep dive today on acute diverticulitis, something that we all deal with as medical microbiologists.
Yeah.
We're going to be using the World Health Organization's uh, Aware Antibiotic book, specifically Chapter 32, so we make sure we hit all the key points.
Right.
Um, you can think of this as your one-stop shop to refresh your memory on acute diverticulitis or even prep for those tough rounds.
It's definitely a common topic
Yeah.
and always good to review the latest guidelines and management strategies.
Absolutely. So let's start with the basics. What exactly is acute diverticulitis?
Well, you can imagine these little pouches called diverticula forming in the wall of the colon, and when one or more of these get inflamed, well, that's acute diverticulitis.
Okay, so I'm picturing these little pouches now. What would bring a patient with acute diverticulitis into the clinic? What are they experiencing?
The classic presentation is pain often in the lower left abdomen,
Okay.
along with fever, nausea, and maybe even vomiting. You might also see changes in bowel habits like constipation or diarrhea.
Oh, wow. So it can really vary.
It can.
So that sounds pretty uncomfortable. What are the first steps to figuring out if it's really acute diverticulitis?
Well, besides a good history and physical exam, we really need to look at both laboratory and imaging findings.
Okay, so let's break those down one by one. What kind of lab tests are we ordering?
First, we've got our standard blood tests. A complete blood count, or CBC, is crucial to check for those signs of infection,
Right.
like an elevated white blood cell count. And things like C-reactive protein and procalcitonin can also give us clues about how severe that inflammation is.
So we're looking for those telltale signs of inflammation, right?
Exactly.
What about from the microbiology perspective? Are there cultures we should be thinking about?
Well, for straightforward cases, routine microbiology tests might not be necessary.
Oh, interesting. Okay.
But if it looks more complicated, blood cultures are a must. And if there's an abscess present and we can get a sample of the fluid analyzing, that can really help us target our antibiotic therapy.
Okay, got it. So we're adjusting our microbiology workup depending on how severe the case is.
Yeah.
What about imaging? What's the gold standard for diagnosing acute diverticulitis?
An abdominal CT scan is our go-to imaging modality.
Okay.
It can clearly show us those inflamed diverticula, any abscesses, and whether the inflammation has spread beyond the colon wall.
So the CT scan helps us determine if it's a simple case of localized inflammation or if it's something more complicated.
Exactly.
Okay, so let's say we've confirmed the diagnosis. Now what's our next step? Do we jump straight to antibiotics or are there other options?
Well, that depends on whether the diverticulitis is classified as uncomplicated or complicated. In uncomplicated cases, watchful waiting can often be the best approach, especially for immunocompetent patients.
Wait, so we don't always need to reach for the antibiotics right away?
Not always.
Interesting.
These uncomplicated cases can often resolve on their own with bowel rest and a liquid diet.
Yeah.
But if the symptoms are severe or don't get better after a few days, or if the patient is immunocompromised, then we need to think about antibiotics.
Okay, that makes sense. So we're taking a more tailored approach, considering the individual patient and the severity of their case.
Absolutely.
Speaking of antibiotics, when they are necessary, what are our go-to choices? What does the WHO recommend?
Well, the WHO's AWARE guidelines provide a great framework for choosing the right antibiotic.
Okay.
For mild, uncomplicated cases, amoxicillin clavulanate is often a good first-line choice.
Got it.
It covers a broad spectrum of bacteria that we typically see in diverticulitis.
So we're starting with that broad spectrum approach to make sure we're hitting all the usual suspects.
Right.
What if we need to escalate therapy? What if that doesn't work?
If the patient isn't getting better or we're concerned about a more complicated case, we can step up to a combination like ceftriaxone and metronidazole.
Okay.
Ceftriaxone targets those gram-negative bacteria, while metronidazole takes care of the anaerobic bacteria.
So we're tailoring our antibiotic choices based on how severe the infection is?
Right.
And what about dosage and duration? Are there any standard recommendations for that?
The WHO recommends adjusting the dosage and duration based on the individual patient and the severity of their diverticulitis.
Okay.
For example, a typical dose of ceftriaxone might be 1 to 2 grams intravenously every 12 to 24 hours, while metronidazole could be 500 milligrams IV every 8 hours.
So we're considering factors like how sick the patient is, their kidney function, and any potential drug interaction.
Exactly.
What about the duration of treatment? Is there like a standard course?
For uncomplicated cases, a 5 to 7 day course of antibiotics is often sufficient. But for those complicated cases, we might extend that to 10 to 14 days or even longer, depending on how well the infection is responding.
Okay, so we're being thoughtful about not only choosing the right antibiotic, but also adjusting that dosage and duration to really optimize treatment. Now, before I move on to some real-world scenarios, I want to make sure we touch on pathophysiology. What's actually happening in the gut to cause this inflammation?
Well, it all starts with those diverticula we talked about earlier.
Yeah, those little pouches.
These little pouches form in weak spots along the colon wall, likely due to increased pressure from things like straining during bowel movements.
So those pouches are like little ticking time bombs just waiting to get inflamed. What triggers that inflammation?
The exact cause isn't always clear, but we think it involves a combination of factors.
Okay.
For example, trapped fecal matter or bits of undigested food can irritate the lining of the diverticula, leading to inflammation. Changes in the gut microbiome might also play a role.
So it's not just one thing. It's a perfect storm of events that sets off that inflammatory cascade. And speaking of the microbiome, what are the most likely pathogens we're dealing with in acute diverticulitis?
Think about your typical gut flora. The most common culprits are gram-negative bacteria like E. coli and anaerobic bacteria like Bacteroides
It's
fragilis.
the usual suspects.
Right.
But the WHO guidelines also mention this increasing threat of multi-drug resistant organisms. Are those something we need to be concerned about in acute diverticulitis?
Absolutely. We're seeing more and more cases caused by ESBL-producing Enterobacterales, which are basically bacteria that have developed resistance to many of our commonly used antibiotics.
Okay, so we can't assume that those traditional antibiotics will always work. We might need to consider broader spectrum options or even combination therapy. Now, before we wrap up this section, I know you've got some exam-style questions up your sleeve to test our knowledge. Ready to put us through the paces?
Let's do it. All right, let's see if you've been paying attention. First question. A 50-year-old patient comes in with those classic diverticulitis symptoms, left lower abdominal pain, fever, nausea. Their blood work shows elevated inflammatory markers, and the CT scan confirms the diagnosis. What's your initial management strategy?
Okay, so we've got a confirmed case of acute diverticulitis, but we need to figure out if it's uncomplicated or complicated before we jump into treatment.
Exactly. So let's say for this case, the CT scan doesn't show any signs of complications like an abscess or perforation. What would you do?
Well, since it seems to be uncomplicated and we don't have any red flags that suggest the patient is immunocompromised, I'd probably lean towards watchful waiting. We could start with bowel rest, a liquid diet, and close monitoring.
That's a good approach. Uncomplicated cases often resolve with that conservative management. But what if the patient doesn't improve or their symptoms get worse after a few days of watchful waiting?
Then we definitely need to reconsider and add antibiotics.
Perfect. On to question 2. A 70-year-old patient with complicated diverticulitis is started on intravenous ceftriaxone and metronidazole. They're showing some improvement, but their blood cultures grow E. coli that's resistant to both ceftriaxone and ciprofloxacins. What do you do next?
Okay, so now we're dealing with a multi-drug resistant organism.
Yeah.
That complicates things. We need an antibiotic that can tackle this resistant E. coli.
Exactly. What would be a good option based on those WHO work guidelines?
Well, since we're dealing with a complicated case and a resistant organism, I'd think about escalating to a carbapenem, like meropenem.
You got it. Meropenem is a good choice in this scenario because it has that broad spectrum coverage and is often effective against those ESBL-producing Enterobacterales. Remember those. They can produce enzymes that break down many of our commonly used antibiotics.
Right, those ESBLs are a real challenge.
Yeah.
So meropenem would be a reasonable next step to make sure we're adequately covering this resistant infection.
Excellent. Ready for question 3?
Bring it on.
A 35-year-old patient presents with right lower abdominal pain and tenderness. They have no fever, nausea, or vomiting, but they do have a history of travel to Southeast Asia. A CT scan shows thickening of the bowel wall and the right lower abdomen. What's on your differential diagnosis?
Right lower abdominal pain makes me think appendicitis, but the travel history throws another possibility into the mix. Could this be something we need to consider from a global perspective?
You're on the right track. While acute appendicitis is a common cause of right lower abdominal pain, this patient's travel history really broadens our differential. In areas where it's prevalent, parasitic infections like Enterobius vermicularis could be a factor.
Ah, those pesky pinworms. So even though classic diverticulitis usually presents with left lower abdominal pain, we can't rule out diverticulitis or other possibilities in this case. We really need to consider the patient's individual circumstances and travel history.
Absolutely. Good reminder that textbook presentations aren't always the rule. Now for question 4. What dietary advice would you give a patient who has recovered from an episode of acute diverticulitis to help prevent future episodes?
This one's all about prevention. We talked earlier about how a low-fiber diet can increase the risk of diverticulitis, so I would definitely emphasize the importance of a high-fiber diet.
Spot on. Fiber is key for keeping things moving smoothly through the digestive tract. What kinds of foods would you recommend?
I'd encourage them to load up on fruits, vegetables, whole grains, and legumes. Aiming for at least 25 to 35 grams of fiber per day is a good target. And of course, staying hydrated is essential, especially when increasing that fiber intake.
Great advice. And don't forget to remind them to make those dietary changes gradually to avoid any digestive upset.
Right, slow and steady wins the race. Okay, last but not least, question 5. A patient is diagnosed with acute diverticulitis and is started on appropriate antibiotics. What's an important aspect of their follow-up care that we as medical microbiologists need to emphasize?
This is where our role in antimicrobial stewardship comes in.
Right. We need to make sure we're using antibiotics responsibly to avoid contributing to that growing problem of antibiotic resistance.
Exactly. So in addition to monitoring the patient's clinical response to the treatment, we should also review their cultures and sensitivities.
And if the cultures show that the bacteria are susceptible to a narrower spectrum antibiotic, we can de-escalate therapy to a more targeted option.
You got it. That's a key principle of antimicrobial stewardship, using the right antibiotic at the right dose for the right duration, and always being mindful of that potential resistance.
So we've covered diagnosis, treatment, and even touched on some of those global considerations. But before we wrap up, I'd like to hear more about the epidemiology of acute diverticulitis. Who's most likely to develop this condition?
Well, age is a big factor. It's actually pretty rare to see acute diverticulitis in folks under 40.
Oh, wow.
But after that, the risk starts to climb,
Okay.
especially in those over 60.
So as we get older, those little pouches in our colons become more prone to causing trouble. Are there other risk factors besides age that we should be aware of?
Diet plays a huge role.
Okay.
Folks who eat a low-fiber diet are at higher risk, and that's unfortunately pretty common in many Western cultures.
There's that fiber again. It really does seem to be the key to a happy gut. Anything else that can tip the scales toward developing diverticulitis?
Well, we also need to think about lifestyle factors like obesity, lack of exercise, and smoking, which can all increase the risk. Certain medications like NSAIDs and corticosteroids have also been implicated.
So it's a combination of factors: age, diet, lifestyle, and even medications. It's like a puzzle, and all these pieces can contribute to developing this condition. Now, shifting gears back to treatment, what's the typical duration of antibiotic therapy for acute diverticulitis?
The WHO's AWARE guidelines recommend tailoring the duration based on the individual patient and how severe their infection is. For uncomplicated cases, 5 to 7 days is often enough, but for those complicated cases, we might need to extend that to 10 to 14 days or even longer if the infection is being stubborn and slow to respond.
So we're individualizing treatment, just like we talked about earlier, with those antibiotic choices. Now, thinking about the long-term management of patients who are prone to those recurrent bouts of acute diverticulitis, what kind of advice can we give them to prevent those future episodes?
Well, the mainstay of prevention is that high-fiber diet we keep coming back to.
Okay.
It's crucial for promoting regular bowel movements and preventing that buildup of pressure in the colon.
Right. We want to keep things moving smoothly and avoid those pouches getting irritated.
Yeah.
What else can we recommend?
Staying hydrated is important, especially when increasing fiber intake. Regular exercise can also promote healthy bowel function.
Yeah.
And of course, if they smoke, quitting is essential.
Absolutely. So it's a holistic approach focusing on both diet and lifestyle modifications. We're not just treating that acute episode, but we're really empowering our patients to take control of their gut health and hopefully prevent those future problems.
Exactly. And as we wrap up our deep dive into acute diverticulitis, I want to leave our listeners with one final thought.
Okay.
It's so important to stay informed about the latest guidelines like those from the WHO and to consider each patient's individual needs when making treatment decisions.
Great advice. And I'll add that antimicrobial stewardship is critical too. We need to use these life-saving drugs responsibly to preserve their effectiveness for years to come.
Well said. It's all about finding that balance between effectively treating infections and minimizing the risk of antibiotic resistance.
Thanks for joining us on this deep dive into acute diverticulitis. We hope you found it informative and engaging. And remember, keep those microbes in check.